next up is going to be a team talk. It's going to be Dr. Anand Swaminathan and Dr. Ken Milne. If you're a late riser and just joining us, they've both spoken to us already. I can give Swami's talk a grade of A, and I can give Dr. Milne's talk a grade of A.
Poser.
So the fact that both of them are going to give a team talk now, I think is going to be outstanding. It is on evidence, non-inferiority, and big pharma.
Woo! Big topic. All right, so what we've got planned for this next hour is that Swami and I are going to talk about evidence-based medicine and how evidence-based medicine has been hijacked. And I'm going to talk a little bit about that aspect of it. Then Swami's going to come up and pace around. Right? I'm going to say that he doesn't like to stand behind the podium. I'll let you decide why.
How dare you? Short jokes.
Who said it was a short joke? He's a good-looking man. He wants to move around. I just had to get back at him. And then he's going to talk about FOMED, free open access to medical education. And then we're going to do a live recording of the Skeptic's Guide to Emergency Medicine. We're going to show you the merger of evidence-based medicine and FOMED. It's going to combine, and you're going to be part of the show. And this is going to be this week's show that'll be posted this weekend for the Skeptic's Guide to Emergency Medicine. So we think that would be very meta. So if we're going to be talking about evidence-based medicine, I always like to define it. And this is David Sackett from McMaster University. And Dr. Sackett said that evidence-based medicine is the conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of individual patients. So there's some key things in there, and I would tweak it for 2019 just slightly. So conscientious, right? You've got to be conscious of the choices you're making. And you have to be very explicit as to why you're making certain choices. Why did you decide that? Some transparency there. Very explicit about what you're doing. And then you use your clinical judgment. You have to be judicious in that. And look for the best evidence and be able to determine and critically appraise what is the best evidence. And then individual patients, and that's key. We can't forget to involve the patients in that care for evidence-based medicine. The only slight tweak is I would put, instead of making in the care of individual patients, I would add the word shared decisions in the care of individual patients, so that we're sharing that conversation and decision with them. And I know I had the Death Star in the previous Venn diagram of evidence-based medicine, but here is the Venn diagram that I've really created for evidence-based medicine. So you have the literature, and we're going to go through a paper. That's what we do every week on the SGEM. We're going to do a structured critical appraisal of the literature. But that's only one component. And I know a lot of the critics of evidence-based medicine are like, oh, it's just cookbook medicine. The paper said this, so you should do that. No, the paper said this. You need to interpret that and apply your clinical judgment. It guides our care, it informs our care, but I don't think there's really a paper out there that dictates my care, that says in every situation, thou shalt do this. We were talking yesterday before the fireside chat. I do a lot of rural medicine. That's where my home base is. And you know, I operate in a rural environment, and I'm glad you're all sitting down. Oh, please, take your seats quick. Because I've worked there for 25 years. I'm just going to wait for him to sit. I don't want any head injuries. You good? Almost? I don't have a CT scanner. And I practice high quality, what I would consider high quality emergency care without a CT scanner on site. So the most important tool I have is here, right? And I actually do a good history followed by a physical exam. I touch them in a clinical setting, all right? And then sit down and make some decisions. I have to think about what we're going to do. And there might be a paper that says, you know, and I'm just going to grab something, but in renal colic or something, a CT is indicated. right? And you think, okay, well, they'll just go down the hall and get the CT. Well, in my case, I would have to look out the window in Canada and go, yeah, I don't think so. The plows haven't been out yet, right? And I'm going to put the crew at risk, the nurse at risk, and that patient at risk, even though the literature says they should get a CT. Maybe we should wait until the roads are cleared first. And so there are very few, if any, papers that dictate my care. But then I need to use my clinical judgment. I'm a PGY 25. I've been doing this long enough. I think I have established some clinical judgment, and I can interpret the literature in the resource environment I have. I still remember a rural case where a young man got severely injured with his ankle, and he came in with an open bimalleolar fracture. And I'm like, you did this last week. You did this last week. And not to be judgmental. And he said, well, I had to get the beans off. And so he duct taped a boot to the clutch of his tractor so he could take off all the beans and make his income for the year. That's not in the inclusion and exclusion criteria of most papers, right? Did you get your beans off? But if he didn't do that, and so I've learned not to be judgmental and to use my clinical judgment for what I have at my disposal, and then ask the patient what do they value. And that story was to say he valued providing for his family, getting the beans off so he could make the income for a year. He'd worked all year from planting and sowing and maintaining this field. And yes, he hurt his ankle. Yes, he had a terrible fracture. But yes, he had to get the beans off. And that was the most important thing to him. And then there's levels of evidence. And so I alluded to this in the burden of proof slide with that stepwise approach. There are levels of evidence, and this is considered the hierarchy of evidence-based medicine. I have some problems with it. It's not perfect, but it starts with expert opinion. That means me and Swami up here saying, this is what I think you should do. That's the lowest form of evidence, what Ken and Swami said, right? Higher levels of evidence are you get case reports, you get cohorts series, but then people go, oh, it's the double-blinded, randomized, placebo-controlled trial. That's only mid-level, actually. The highest level of evidence is a systematic review on the topic. But my problem with this artificial hierarchy of evidence-based medicine is you can have a very, very poorly done systematic review, and you can have a great, well-done randomized control trial. And I usually, again, describe this in country terms. I grew up on an apple orchard, an apple farm, and we always talk about making really good apple pies. My mom, apologies to anybody out there, my mom makes the best apple pie. It was my grandmother until my grandmother passed, and then it became my mom, and it's getting passed down. She makes the best apple pie, but you have to have great ingredients. And that's what a systematic review is about. If you don't have great ingredients, if you don't have really wonderful fresh apples that aren't filled with worms and stuff like that, we called it sweeping the orchard in the day, where we take everything off the ground and throw it in the bin. I don't drink apple juice, because that's where apple juice came from, the sweeping the orchard. Now they don't do that anymore, but that's how it used to be done. You'd sweep the orchard. You have great sugar and cinnamon and all these great ingredients. But if you don't, if you have a whole bunch of observational studies that were unblinded or biased or whatever, that's crap. And we call those cow pies. And adding cow pie to an apple pie doesn't make the apple pie taste any better. All right? And so if you have a systematic review that's full of observational studies, not high-quality randomized control trials, but you get a great study that's properly powered, properly blinded with patient-oriented outcomes, and it's an RCT, I'm going to take the RCT over the crappy cow pie of a systematic review. So it's a bit artificial. And then there's checklists, and we're going to go through a checklist to show you the checklist that we use for randomized control trials, because we're going to present to you a randomized control trial. And these checklists are to probe the literature for its validity. And in this case, all of these checklists are available online on my site under the SGEM Extra episode called Make It So. All right? And it's from the BEAM faculty, the Best Evidence in Emergency Medicine. And I know I did Star Wars earlier. I'm actually more of a Star Trek guy. Okay? And then at the end of the day, evidence-based medicine is the worst form of critical appraisal in medicine. It's the worst form of medicine, except for all the others that have been tried. Do we want to go back to magnets? Right? Do we want to go back to bloodletting, which was the standard of care 200 years ago, and still someone named Alexander Hamilton, not the same one you guys are thinking about, not the song and dance version, but Alexander Hamilton was a Scottish medical student who said, you know what, this bloodletting for camp fever, I'm not so sure it's good to release this evil humor when I've got a septic patient. Now, I know there are some concerns about the Surviving Sepsis Campaign guidelines, the latest guidelines, and the fluid bolus in the first hour. But I'm sure, and I've really looked through those carefully, nowhere did it say bloodletting. Let's remove blood and let's remove volume from someone who's septic. But 200 years ago, you would be considered a little crazy if you weren't bloodletting patients. And until they finally did that randomized trial, wasn't blinded, didn't need to be blinded, because all the bias should have been in favor of bloodletting, right? If the patient died, we are smart individuals that can rationalize anything. If the patient died with the standard of care, or the standard care of bloodletting, what was the problem? Well, we didn't bloodlet them enough. We should have taken out 2 pints of blood, right? We should have taken it out earlier. We just didn't get to the bloodletting soon enough. We didn't have a longest duration of bloodletting. Oh, they're right-handed. We should have bloodlet from the dominant arm. Well, the heart's more on the left. We should have bloodlet from the left arm. You can see all the rationalizations until they did the randomized control trial. Again, it was not blinded. This was a medical student, by the way. So for the residents out there, this was a medical student. They did a 1-to-1 randomization, bloodlet, no bloodlet. At the end of the day, they had a very hard patient-oriented outcome, alive or dead. And to refer to the Princess Bride, no one was mostly dead, right? It was an easy dichotomous outcome. You couldn't fake your death. It's not Elvis. All right? And so what they did was they counted up how many people were alive and dead after they got the standard of care, bloodletting. It was done by the head surgeon at the time. And the no bloodletting standard of care, the bloodletting, the non-bloodletting that was done by the medical student, Alexander Hamilton. And it turns out those who got bloodlet had a death rate in the high 20s%. And you go, okay, well, what about the group that wasn't bloodlet? What was their death rate? 3%. So if you take the absolute difference between the two, it was about 25% absolute increase in death with the standard of care of bloodletting. So that gives you a number needed to harm, or in this case, number needed to kill, an NNK of 4. Which group do you want to be randomized to? All right, so the importance of randomization in evidence-based medicine. Now, there is a concern that evidence-based medicine has been hijacked, and this is by Ioannidis, depending on how you pronounce this, John's last name. And he sent this letter to David Sackett and published this letter about how evidence-based medicine has been hijacked. It's a little bit about the tooth fairy science, but more towards the corruption of the concept. And saying that the agenda of evidence-based medicine to provide the best care to patients based on the best evidence, it's been hijacked. Influential, large, randomized control trials are set up and designed for the benefit of industry. And meta-analysis and guidelines have become factories, right? They just crank out these guidelines and guidelines. And it's not really the original purpose of evidence-based medicine with all these conflicts of interest. And all the national, and not all, but the national and federal research funding are funneled almost exclusively to research that has really limited or little to do with patient-oriented outcomes. It's often about things that Swami and I talk about, which are disease-oriented outcomes, DOs, LOOs, which are lab-oriented outcomes, a new term I'm trying to coin, which is MOOs, because I'm rural, monitor-oriented outcomes. In other words, you gave the vasopressor, the alarm stopped going off in the ICU, and the nurse isn't bugging you. The patient still died, but at least it was a monitor-oriented outcome. The monitor alarms weren't going off anymore. That's a MOO. And what we want is a POO, a patient-oriented outcome. And very little research, they're asking the wrong questions. You need to ask the right questions when it comes to evidence-based medicine. They should be patient-centered. And this is my, of course, Dr. Evil, And so I'm not going to make claims that I can't support. And there's 3 studies about industry funding and conflicts of interest, financial conflicts of interest. And the first one was done in 2003, looked at financial conflicts of interest in biomedical research in general. This was published in JAMA, and the authors stated that, quote, strong and consistent evidence shows industry-sponsored research tends to draw pro-industry conclusions. So we need to be skeptical. The next article about these financial conflicts of interest again gives evidence for pro-industry conclusions, biased study designs, and suppression of negative results. If you organized and paid for a study to show your drug works better and it doesn't, where is your incentive to publish that in a major journal? You don't have any really outside of, you should, desire to publish something like that. It could harm your drug and the thing that you're trying to promote. And then finally, there's a systematic review. And again, these slides will all be available so you can look at the original research. This is by London all, and it reviewed industry-sponsored and researched outcomes. And it was a Cochrane database of systematic reviews. One of the most trusted, but you still need to be skeptical of Cochrane, but one of the most trusted systematic review publishers. And they suggested that industry-sponsored studies are more often favorable, so not always, but more often favorable to the sponsored product than non-industry study interventions. And so you need to be skeptical of these because some evil things, and I mean evil is a bit strong, but we are human beings and we have biases. And what we're finding, and we're going to present a non-inferior study design, and when it comes to non-inferior study designs, non-inferior is, it's a way to say this product wasn't any worse than what's currently available. So it's different than a superiority study. So a non-inferiority study says this isn't worse than. And what usually it comes down to is this much more expensive drug that is convenient to take once a day, once a week, once a month injection at a greater cost, right, is not inferior to the current level. And we're seeing a lot of that, and we're going to present one of those papers. And then finally, so Swami knows he's getting ready to go, is that you need to do in non-inferiority studies, because that's what we're going to be talking about, the intention to treat analysis is when you randomize everybody, as soon as everybody's randomized, you analyze those people in this group, the control group, or the treatment group, regardless of if there's any crossovers or withdrawals or loss to follow-up. That's called an intention to treat analysis. In a superiority trial, when you do that, it decreases the point estimate of effect size, which is good. It's conservative because you want a big effect size to overcome some of the biases. So if you do an intention to treat analysis, this would be a conservative way to evaluate the study and say, I shouldn't reject the null hypothesis. But in a in a non-inferiority study where you want to prove that your drug's not worse, the point estimates are similar, right? If you do an intention to treat analysis, that moves you towards the idea of no effect. But a per protocol has said they were randomized here, they were randomized here, they were crossover. Did they get any drug or did they not get any drug in case of a drug trial? So you only do, did they get the actual protocol? Did they complete the protocol? Did they not complete the protocol? Right? And that exaggerates the effect size. And so that's a more conservative approach for a non-inferiority study. Right? But what people tend to do is do an intention to treat analysis for a non-inferiority study and go, yes, non-inferior has been proven. You're up.
Thank you.
And you wander, so.
So I'm just going to talk a little bit about free open access medical education and how this has a role in evidence-based medicine. And I title this "The Future is Open" because I think it's a really important concept for us to understand how education, how literature has been closed off to the majority of people. I used to work at a place that had this robust library. I could find any paper, anytime, from the comfort of my own home. I'm no longer at a place like that, and I find it very difficult to actually access this stuff. And I'm still associated with the university. It's even more difficult the further you get outside of those ivory towers to actually be able to get the information, to get the literature, and not pay an arm and a leg for it. But I think the future is opening up, and it's going to allow all of us to have this information. And now it's a matter of how we use that information, how we interpret it, and then how we use that to help our patients. Too far? Oh, yeah, it's working out. It's too far away. So this is a... I just have to go off the slides. That's fine. So this was a study that was published a couple of years ago looking at what people are using for their education. And what they found was that 70% of people preferred podcasts for their education over books. So we know that we're moving in this direction already. The problem is that our standard approach to education, traditional education, is fatally flawed. It doesn't work the way that it's supposed to. There's lots of reasons for this. Textbooks are grossly outdated. I apologize for the font issues, but we'll work through it. Textbooks are grossly outdated. How many people here have written a textbook chapter? How long from finishing writing the textbook chapter to publication? Or starting the textbook chapter to publication? 5 years? 6 years? It takes time. The information is automatically outdated as soon as that book goes into publication. And we know this because as soon as the book gets published, the editor, the author, the general editor is already asking you for the next version of that chapter, right? So that's the way it works, and that's a problem. Now, journal articles are better. They're a little bit more recent. There's still a 2 to 3 year lag on them. And one of the major problems with journal articles is that there's about 3,000 of them published every day. So while you were sitting here, you've been wasting time. There's 1,000 articles that have been published that you haven't read. Shame on all of you. We can't keep up with the literature. But even if we could keep up with the literature, we face lots of problems that Ken alluded to with how this is being done, how this literature is put out there, who's sponsoring these studies. Disclosures are getting longer and longer. This is one from just a couple of years ago. It's actually not that bad. That's not that long. I can read all of those words in a short period of time. But the disclosure lists are getting longer and longer to the point where most major journals now do not list the disclosures in the article. They say, if you want to see the disclosures, please go online. Because we don't have enough room in the journal to publish all of the disclosures that our authors have.
May I interrupt for a second?
Please.
I'm going to propose the BMJ does a Christmas article every year, something funny, but it has to be a real study. And I've been thinking about this, taking the font size and making them all equal for conflicts of interest compared to the methods section. And if the conflicts of interest section exceeds the methods section of the paper, how does that associate with the conclusions of the paper? And I'd be willing to do that project.
I think we should do it.
I think we should
Christmas
do it.
issue, BMJ,
Christmas issue
2020.
2020. And we'll come up with a Swami Milne scale or something, like 2-to-1 ratio for conflicts of interest to methods.
It might not be as well read as Virgin Births in the UK, or how long does a box of chocolates last at a nursing station?
Parachute trials.
Parachute trials, some good ones. So other ways we can get education is by going to conferences like this, which are fantastic. You get much more updated information, but we can spend a lot of money traveling for conferences, and unfortunately, we still also have to work clinically. So we all know we take 3 days to go to a conference, now all of our shifts get packed together, and so we can only do it so many times a year. So we have to find innovative ways to reach education, and I think free open access medical education, podcasts, blogs, this offers us that opportunity. And I think that the reason that these innovative forms of education are better are threefold. The first is that they are stronger than our traditional methods. Ken mentioned this quote earlier from Marshall McLuhan. Anyone who tries to make a distinction between education and entertainment doesn't know the first thing about either. We have to blend these things together. It doesn't mean that it's all song and dance with no content. It has to be both. It has to be engaging. You have to want to read or listen to whatever is being put out there. If you don't, then it doesn't matter how good the information is, no one's ever going to listen to it, no one's ever going to use it. Free open access medical education allows for repetition. It allows for you to decide, I didn't quite catch that point, can you go back? You can't do that here. If Ken or I speaks through something very quickly, you can't be like, I'm sorry, could you repeat everything you just said about everything?
You can do that because I'm recording this and Facebook's live streaming it, so you will be able to watch this later.
Which is the power of having these different approaches to getting our education done. I think that foam is also better. It is filterable. We are able to filter down what it is that we actually need to know, what we want to have, what information we want to reach us. So we don't have to just have the whole internet before us and then try and find the information. We can actually change and manipulate that. And if anyone's interested in doing this, there are these great programs online. The one that I use is called Feedly. It's free. I don't take any money from them. And it allows me to filter the internet to the information I want to see and I want to hear. In addition to that, it is just-in-time education. We work nights, we work evenings, we work day shifts. I'm not ready to be taught necessarily when you are ready to teach me. And you may feel the same way about this. For my residents, I have residents who are working overnights and then they miss Wednesday conference. Or they're working a day shift on, an evening shift on Wednesday, and so they don't want to come in because they're not going to be keyed to learn. We have to be able to provide that education to them when they're ready. If I have a resident Friday night at 10 o'clock, that's when they want to study, that's when they want to learn about something, great. I need to give you a way to get that information. It cannot be simple didactics, simple lectures. It's got to be beyond that. It's got to be something accessible to us. Foam allows access to the world's experts and knowledge with a single click. That's the power of what we can do with this. And then finally, and Ken alluded to this, foam is faster. It is better for knowledge translation than what we are currently using. And that's what we have to look at. Ken talks about cutting the knowledge translation window down from 10 years to 1 year. We know that even when something has been accepted as clinical practice in guidelines, it still can take 10, 15, was it 17?
17 years
17
for 14%
years
of the information.
to make it down to us at the bedside. We have to be able to cut that window down. If there are 3,000 journal articles out every day, we need to be able to narrow that down to discrete messages. But we also have to trust the source that's coming from. Now currently, right now, I can say that none of the large foam blogs, podcasts are taking industry sponsorship. And that is critically important to our ability to trust those resources. I can tell you that nobody sponsors the SGEM, nobody sponsors me for my work on Rebel or my work with MRAP. We don't have industry funding, which means we can still be honest and unbiased, or at least we can do our best to do that. We are becoming less and less able to trust the resources that we used to trust in the past. We'll get into this a little bit with the specific article that we're talking about, but the venerable New England Journal of Medicine is no longer the venerable New England Journal of Medicine. It is not a trustworthy resource because it is biased. There is too much industry funding in the New England Journal of Medicine. And if we can't trust the New England Journal of Medicine, that makes our jobs very difficult. It makes all of our jobs difficult because we can't sit there and analyze and critique every article that comes out and be able to tell whether I should use this at the bedside or not. Now, Ken and I kind of kidded around about what we were going to title this particular talk. I wanted to say that the New England Journal of Medicine is a piece of shit. That didn't play very well.
As the Canadian, I said, it's not my favorite journal.
Yes. But we're going to talk about what our issues are specifically with that one, but it's not just about the New England Journal of Medicine. It's about all of these major journals, and we have to be skeptical of them. So I do think that foam is stronger, it's better, it's faster. It is the Superman of superheroes. It is all of these things together. We simply now need to know how to use it. And what we're going to do, what Ken and I are going to do, is give a demonstration of what we try to do, what Ken tries to do every week, what we try to do to get that information out there. And again, Ken does not pay me, so when I say this, you can trust that I'm being as honest as I can be about this. I think analysis and critique of journal articles is a difficult skill. All of us had journal club in residency. You don't have to tell me whether you thought your journal club was great or not. I will tell you that when I was in residency, my journal club sucked. Bill Paolo is in the back. We were residents together. He will tell you that our journal club sucked. I learned nothing. I learned nothing about critiquing articles through that process. And what I tell my residents now, what I have done over the last 6 years or so, is I look at what article Ken's reviewing. I pull that article, I read it for myself, I critique it, and then I listen to his critique. And I see if I'm matching up with that. Am I getting the same points? Am I getting different points? And that's how I'm starting to learn to analyze these articles and get better at critiquing them. Now I'll tell you that the first step in this is skipping right from the beginning of the paper right to the methods. You can read the 2-3 paragraphs in the methods and you can say, I'm not wasting my time with this piece of crap. Just from that couple of paragraphs, you can tell whether this is valuable information or not. And we have to get better at doing this because the journals, big pharma, they're getting better and better at pulling the wool over our eyes. We have to wake up and do this well. So that's what we're going to do together. We're going to take an article from the New England Journal of Medicine. We're going to dissect it a little bit, see whether it should affect any of our care, and hopefully at the end of this, we'll have a little bit of a conclusion on it. Mm-hmm. So let's see, Ken, I'm going to skip to your last sentence. And we're ready to go. Let me reposition our monitor here, our script.
So I'll set this up while he's putting, because we have show notes that go with it, so we can give you the correct information. And, oh, thank you. And he, he's much younger than I am, So, being on the wrong side of 50 now, I'm like, what's that say? Okay. Is there any way to make that font bigger for me? See, I'm apologizing. Yeah, there, that's good. That's good. I can read that. All right. And so I've got a recording device up, and we have our own microphones. So we're going to be able to record this, and I'm going to be able to post-produce it for my show this week. So I'm going to hit record, so you are being recorded. Just so you know, fair warning, you've all agreed. So if you don't want to have anything, blurted out about the New England Journal of Medicine or anything like that, you're being recorded. All you have to do is use your frontal lobe and censor yourself with a locus of control. But we do want audience participation. We do want to give a shout out to the fact that we're here at the New York ACEP state meeting and at this beautiful resort and stuff like that. So we will give woohoo cheers at certain points, okay? And I'm relying on you to be involved. So here we go. Oh, and by the way, all of my podcasts start with theme music. Traditionally, it's from the 80s because I'm stuck in the 80s, and that's why I give my residents a memory stick with 5 80s movies on it, so they get my jokes.
They're not allowed to come to shift until they've watched these movies.
I call it flipping the classroom. So they've got to see Ferris Bueller's Day Off, they've got to see Top Gun, they've got to see Princess Bride. This is core content as far as I'm concerned. Thank you. Anyone? Bueller? And they just look at me like, you're so weird. So I come up with 80s music. Just because I can't sing doesn't mean I won't sing. And so I try to sing the intro, so bear with me. And this song is from the 80s, believe it or not. But I don't have a recording of it, so you're just going to have to go by my version. And my version is to the song, Oh My Darling Clementine. Okay? And
Wrong 80s.
No, it's 1880s. I said 80s. You didn't ask the follow-up question. Which 80s? Be skeptical.
Now? This is good stuff.
No, yeah. This is gold, baby. Gold,
It's not
Jerry.
going to be good when I say it again.
Gold, Jerry. Okay, here we go. Card protected. Here's what we'll do. Can you slip that out?
I hope so.
No, it's just that. I must have put the little tab on it. The little tab that allows you to write the card. Last time I had it in. Pop it. Click it. There it is. There we go. Slide it back in. And this is why, when you're coming through high school and you're getting beat up and thrown into lockers and stuff like that and being part of the AV club, this is when it was cool to be part of the AV club. Because we could do this. I didn't even think to check to see if the card was protected. Checklists. Test 1, 2, yep. And we're recording. Okay, so here we go. Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is July 10th, 2019, and I am your skeptical host, Ken Milne. The title of today's podcast is Omadacycline, Omadacycline, Omadacycline. Is it non-inferior to Lazinolid for skin and soft tissue infections? And our guest skeptic is Dr. Anand Swaminathan. Anand is an assistant professor of emergency medicine at the St. Joseph's Regional Medical Center in Paterson, New Jersey. He is a deputy editor for EMRAP and associate editor for Rebel EM. Welcome back to the SGEM, Swami. It has been too long.
Yeah, it's been a while since we actually got to do a podcast. It's great to be on this together.
Where'd you put the clicker? Did you take the clicker? There you go.
That's going to be edited out for post-production, right?
Of course.
We have a lot of work to do.
I know. I like to have it running so smoothly. All right. So, and here's our guest skeptic. And this is when I came down to visit him at Bellevue, and he was kind enough to have this wonderful Canadian T-shirt on when I came through the door. As you may tell, audience, we are recording this live. Swami, tell the SGEMers where we are today.
So we're broadcasting today from New York ACEP's annual scientific assembly, where there's about 320 emergency physicians who have gathered in the beautiful Adirondacks at the Sagamore Hotel.
it is such a great group of people, a wonderful spot to have a meeting. When I first arrived here, I was like, wow, this reminds me of one of my favorite 80s movies. Anybody got a guess? No.
You guys are just a really dark place.
Yeah.
For the podcast listeners, they went with The Shining.
The Shining. No, I went, and this is the slide is a bit of a hint. Dirty Dancing, because nobody puts Swami in the corner.
So I hate to admit this. I admitted this yesterday to Dr. Strayer. We were driving up. I've never actually watched the entire movie of Dirty Dancing, but I recognize that this is similar to what it would look like.
It's a little fancier, but boy, is it a beautiful place. Now, we always seem to have great episodes together, don't we?
I absolutely think so. I think this is our 7th or 8th recording together.
And I did a little research before putting this one together.
The shocker, you did some research.
I did some research.
Okay.
And I looked at what are the top 5, 5 is my favorite number, what are the top 5 SGEMs for downloads?
I'm going to go ahead and guess that they are none of the ones that I've done with you.
They are none of the acupuncture ones, actually.
That's for sure.
But of the top 5 of all time, you were guest skeptic on 4 of the top 5.
Okay, that's a bit of a fucking shock to me. Oh, I'm sorry. I know I cursed. Just give us our explicit tag. High five to me.
I've never had an explicit rating on my
I'm going to
podcast.
make that change today.
But I think it just speaks to what an amazing educator you are, Swami. You have a gift for knowledge translation. And in my opinion, I've got this objective evidence of downloads, but in my opinion, you have one of the best voices out there for podcasting.
I appreciate that, Ken. There was a time where I was being touted as the tallest in podcasting. And then someone met me in real life, and they said, wait, you're Swami? I thought you were the tallest person in podcasting. And then we realized that sarcasm doesn't work as well in podcasts as we thought it did.
It doesn't come across as well.
She was quite underwhelmed by meeting the tallest person in podcasting.
Now, people always talk about, the banter at the start of the podcast. I find it fun. I find it enjoyable, as long as we don't talk about the weather, right?
Absolutely.
But
it's beautiful outside.
It's beautiful outside.
There we go.
Yeah.
Checklist.
Checklist, check. All right, so we start each of the podcasts with a case to frame the conversations and talk about the paper. So, Swami, you have a case for us.
Yeah, so we've got a 22-year-old woman who presents with redness and swelling of her left lower leg from the top of the ankle to about midway up the calf and the medial surface of the leg. Her skin is warm, she's got mild tenderness, there's no fluctuance, there's no crepitus, she's pretty well appearing without a fever, she's got no prior medical history, no history of allergies. You're about to write her a prescription for a little Cephalexin when you remember reading about a new antibiotic that recently became available for skin and soft tissue infections called omadacycline.
Omadacycline?
Omadacycline.
I don't know. Tomato. Well, we've covered cellulitis and abscesses a number of times on the SGEM, and I'll list those in the show notes so people can click on those prior episodes. Often we have a guest skeptic on those shows, and that guest skeptic is an amazing physician assistant named Chip Lang from Total EM. He is fantastic. And, as an advanced care practice provider, he is setting a new standard, and he does his own podcast, and he's now even running his own ultrasound course.
So I think we have to be excited when we see the production and release of new antibiotics. It's pretty rare. There's not a lot of money for Big Pharma to make antibiotics, and so as we see more and more resistance, it continues to mount. We continue to need new options as our other options narrow. So it's actually exciting to see these articles being published.
Well, recently, the New England Journal of Medicine published 2 articles on a new antibiotic that was recently FDA approved, omadacycline. And you know me, Swami, I'm skeptical at the best of times, but the New England Journal, it's not my favorite journal these days for a number of reasons.
We kind of went over this before, but Ken is being as diplomatic as he possibly can, being a complete Canadian and not being too critical. The articles here compared omadacycline to moxifloxacin in the treatment of community-acquired pneumonia. And then the other article, the one that we're going to talk about today, compared omadacycline to linezolid in the treatment of skin and soft tissue infections. Both studies yielded promising results for the new drug, at least from the conclusions that we read in the articles, and they should be cause for excitement.
However, significant biases, methodological flaws, and poor selection of a comparator treatment should temper our excitement. So we move on to looking at What is the clinical question we're going to address in today's podcast?
Is omadacycline non-inferior to linezolid in terms of early clinical response and treatment of skin and soft tissue infections?
And the reference, Swami?
So this is by O'Riordan et al., omadacycline for acute bacterial skin and soft tissue infections, New England Journal of Medicine, 2019.
And so that's the clinical question. Then we run through the PICO. What was the population?
Patients older than 17 with a skin infection. That includes cellulitis, erysipelas, or major abscess.
And then there was a number of exclusions, and I'll list those in the show notes. What was the intervention?
So the intervention was either omadacycline 100 milligrams IV Q12 for 2 doses, followed by 100 milligrams Q24 for at least 2 more days, with the option to transition to 300 milligrams Q24 for 7 to 14 days total.
So that was the intervention, and then you have a comparison group. What was the comparison?
So comparison here was linezolid 600 milligrams IV Q12 with the option to transfer to 600 milligrams Q12 by mouth for 7 to 14 days, and this was after at least 3 days of IV treatment.
And then we look at the outcomes, the primary and secondary outcomes. What was the primary outcome in this study?
The primary outcome was early clinical response defined as survival with a reduction in the lesion size by at least 20% at 48 to 72 hours after the first dose.
All right, and the secondary outcome?
Clinical response post-treatment, so this was at 7 to 14 days.
So the author's conclusions were, quote, omadacycline was non-inferior to linezolid for the treatment of acute bacterial skin and skin structure infections and had a similar safety profile, end of quote. So now we move on to this checklist that I was referring to. And for randomized control trials, the checklist goes to 11. All right, and so we're going to run through those, and it's sort of a yes-no answer, or sometimes it's unsure because we can't find it in the information. So for the first question to probe the literature for its validity, from our standpoint is, did the study population include or focus on people in the emergency department?
So we actually don't know. They didn't really specify in the manuscript.
Were the patients adequately randomized? Because we know how important randomization is.
So they were. They used computer-generated block sequence randomization. Ken mentioned before how envelope randomization isn't the way to go. This is a much more robust way to randomize.
Yeah, the third question is about, did the randomization process, was it concealed? And that's why we emphasize that.
So it was. The investigators and sponsors of the trial were unaware of treatment allocation.
And then it gets into that intention to treat and per protocol analysis. So we want to know, were the patients analyzed in the groups to which they were randomized?
So they were. They actually did both an intention to treat and a per protocol analysis of the data.
And did they recruit the patients consecutively? Did they avoid selection bias?
So this one we don't really know. We're unsure. It didn't really specify whether they enroll patients consecutively, and we'll discuss that a little bit later too.
And an important aspect is, were both groups at baseline similar?
Yeah, I think they were.
Okay? All patients and that are all participants, and that means the patients, the clinicians, the outcome assessors were all of them unaware of the group allocation.
Yes.
Okay? All groups were treated equally except for the intervention.
It appears so.
Was the follow-up complete? And we usually use a target of more than 80% had follow-up.
So I said yes. We're not 100% sure, but we think that follow-up was at least 80%.
Were all important patient outcomes considered?
I don't think so, and this is a bit of a tough one based on what we're studying, and we'll come back to that as well.
And the 11th and final question is, was the effect size large enough and precise enough to be clinically significant?
In this case, no. There was no statistically significant difference in this non-inferiority trial.
Okay, and so that's leading up to the results section. And when it comes to the results, they enrolled 655 patients. Oh yes, 655 patients from 55 sites in the US, Peru, South Africa, and multiple countries in Europe. The median age was 47 years and 2/3 were men. It was about 33% were wound infections and 33%-ish were cellulitis and about 33% were major abscesses. But Swami, what was the main result?
So the main result was that omadacycline was non-inferior to linezolid for skin and soft tissue infections.
And so for that primary outcome, just to remind you, this is early clinical response defined as survival with a reduction of a lesion size of at least 20% at 48 to 72 hours after the first dose. How about the secondary outcomes?
So secondary outcome was clinical response post-treatment at 7 to 14 days. That one was also non-inferior for omadacycline.
And so this is getting to my favorite section. This is where we get to talk nerdy, and I love talking nerdy with you, Swami.
There's no one I'd rather talk nerdy with. We have another podcast that we do where the segment that we do is called Time to Talk a Little Nerdy.
Time to talk a little nerdy. And so we have 5 points that I wanted to go through when I was reviewing this study. And the first one was about funding. And our current research paradigm involves pharma. But just because a study is funded by industry, that's a reality. Studies are funded by industry. That doesn't make the results invalid, but it should make us more skeptical. So here's what they said in the actual methods section. Quote, Paratech Pharmaceuticals designed and conducted the trial and prepared the statistical analysis plan. Analyses were performed and data interpreted by Paratech Pharmaceuticals in conjunction with the authors.
I have a hard time understanding exactly what the authors did based on that line, but they also go on to say that the authors vouch for the integrity, completeness, and accuracy of the data and analyses and assume responsibility for the fidelity of the trial to the protocol and statistical analysis plan, which are available on the New England Journal of Med.org.
Yeah, but the very next sentence was, quote, a medical writer who was supported by the sponsor assisted with the preparation of the first draft of the manuscript. Where do you think, this is a question for the audience, where do you think their loyalties lie? Do you think their loyalties lie towards science or to their employers?
And again, it really speaks to what were the authors exactly doing in the study? Were they simply just editing after the drug company wrote the paper? And we don't know. We don't know, but this leaves a lot of things to the imagination for sure. Number 2 of our topics was selection bias. Now, there may have been selection bias in this community-acquired pneumonia study as well as the one on skin and soft tissue infections. They didn't really state whether the patients were enrolled consecutively or not, and it's unclear how many patients presented with the problem that were actually included in the study. So they might have just gone through and said, yes to this one, yes to this one. I don't think that this person should be randomized. And we don't know how that was done, and ideally, they would just take all comers and randomize them.
And so we're sneaking that second paper about community-acquired pneumonia that was treated with omadacycline into this analysis, because if you look at that paper on community-acquired pneumonia, they had only 774 patients were enrolled over 14 months across 86 sites. So let's do the math. That's less than 1 patient enrolled per month per site with pneumonia. Really? You didn't think they had more patients that presented to the department that would have qualified? And then when you look at the skin and soft tissue infection study, which we're looking at today, they had 627 patients enrolled in this study over 12 months, over 55 sites. I'm going to do the math for you. That's 1.2 patients per site per month. Who here sees more than 1.2 patients per month with cellulitis? How many see more than 1 patient per day, per shift with cellulitis? So we're concerned that there may have been some selection bias.
So the average ED obviously sees way more of these presentations that were included here, and that makes us think that there were a lot of patients who weren't approached, or they were approached and someone determined, we're not going to put this person in this particular study. Now, additionally, in that community-acquired pneumonia study, there was about a 1% absolute difference in mortality favoring moxifloxacin. So while there might be a non-inferiority there for their primary outcome, you killed more patients with your new drug. My patients do care about whether they were, well, actually, the patients don't care about whether they were killed or not because they're unable to care about being killed or not, but everybody else cares about whether that patient died. So in this particular case, yes, it might be non-inferior, but it's worse than the standard treatment because there's a 1% absolute increase in mortality. Now, Ken, in these particular EDs, since they were only seeing 1 patient per month with pneumonia, maybe 1% difference didn't really affect them. But in real EDs, where we see hundreds of patients with pneumonia, we're talking about some real numbers here. 1% absolute difference in mortality.
It's a pretty hard outcome. The third point we wanted to talk about was non-inferiority trials. And I talked a little bit about that before, and there's a few things that we just wanted to mention about trial design. Most people understand that a superiority trial is attempting to demonstrate some treatment or intervention is better than another, or better than control, by a pre-specified amount.
A non-inferiority trial doesn't mean that something is equal or equivalent. It's impossible really to show equivalence between two interventions because there's always going to be some small differences between the two groups in terms of sample size and all of these other issues. But there are equivalent trial designs to say things are within a pre-specified range, and that's what this was trying to do.
Yeah, so when you're talking about, there's one thing to say something's equal, which is very hard to say, because if you get a large enough sample size, obviously there's going to be small statistical differences. But when they talk about equivalence, they want to see that point estimate with the 95% confidence interval around that point estimate is within the plus and minus pre-specified intervention of superiority and non-inferiority. But then non-inferiority trial designs are designed to show that some treatment is not worse than another treatment, and researchers can choose a non-inferiority trial design for a number of good reasons. Like, it might be unethical to expose a patient to a placebo. So a non-inferiority trial might be more ethically sound to do. Also, it's less costly to do a non-inferiority trial because you have a smaller sample size, so you expose less people to it. And then finally, safety might come into it.
We don't want to malign non-inferiority studies because they do play a role in the studies that we see. There are reasons to do non-inferiority. If the intervention that you're looking at is cheaper or easier for the patient or more accessible, those are all good reasons to do a non-inferiority study. And so we have to ask, was this drug cheaper? Was it easier? We look at the treatment algorithms for the two drugs being compared. They're about the same, 3 days IV followed by the oral medication. So is it cheaper?
Well, so I did some math and I did some research and I went and pulled different treatment costs, and we can go through those now. So typically we would approach a skin and soft tissue infection with something like Cephalexin. What was the cost of Cephalexin?
So Cephalexin is about $1.60 a day.
$1.60 a day for a course of treatment. How about linezolid?
So linezolid is about $5 a day.
$5 a day. What's this new drug cost?
So omadacycline worked out to about $415 per day, which is a slight difference. And it's interesting because initially when the price point was put together, it was estimated as the same or equal cost to linezolid, but linezolid has since come off patent and is now fairly inexpensive.
Well, one of the key elements of non-inferiority trials is setting a margin considered non-inferior. And in this trial, they looked at omadacycline and they set the margin at 10% based on historic data from controlled trials comparing antibacterial drugs with non-antibacterial treatment. So they compared it to giving someone with a bacterial infection an antibiotic and not an antibiotic, and said we would set non-inferior at 10%.
And that's a big target. When you're talking about non-inferiority studies, the bigger a target you set, the easier it is to hit, right? So if the bullseye is this entire room, even I can hit it with an arrow. But if you make that bullseye smaller, to which point it becomes relevant to the patient, it becomes more and more difficult for them to hit that. They put a big bullseye up there.
Yeah, why not set the margin for antibiotic treatment versus another antibiotic treatment? Set that non-inferiority margin at 5%. And would that change the results? Would they be able to claim non-inferiority if they had a 5% difference set as that margin? But the fourth point we wanted to talk about, and I mentioned this earlier, and this was intention to treat versus per protocol analysis. A quality indicator in most randomized control trials is to see, did they do an ITT? And remember that an intention to treat looks at all the patients immediately after randomization, regardless of what treatment they received. And there can be crossover after randomization, but the patients always get analyzed into the original group allocation. And this is a conservative way to view the results in a superiority trial design.
Now, in contrast, that the per protocol analysis looks at the actual treatment the patient got. This analysis can overestimate the point estimate of any effect and could lead to falsely rejecting the null hypothesis of no difference. So again, we're talking about in superiority trials, we favor ITT or intention to treat over per protocol.
However, it's exactly the opposite in a non-inferiority trial. You want to see a per protocol analysis because it would be the conservative approach. It maximizes the difference Well, an ITT would minimize the difference and move you towards less effect and accepting the null hypothesis, and therefore concluding non-inferiority. And this can be tricky. It can be a tricky concept. And so actually there is a YouTube video on this by Sketchy EBM. So Sketchy EBM talks about ITT versus per protocol analysis, and I'll include the link to that YouTube video for people who want to review that.
One easy way to think about this is if you do a intention to treat analysis, you take all the patients that you see that you put on one drug or another, and when they come back for analysis, you can evaluate all of them as being the same. The softer the outcome you're looking at, the easier it is to say, I think that person got better. I think that person got better. And in a non-inferiority trial, what you would like to do is take all the patients, if you are trying to show that the drug works, take all those patients and say, I think everybody got better. So it's non-inferior. That's how this can be easily gained. And so the softer the outcome is, the larger the margin is, or the larger the target they make, the easier it is to show non-inferiority, and all of those things were done in this study. So Ken, why, with all of that being said, why did they use this approach for the study? Why did they use a non-inferiority design and play up the ITT?
Yeah, it's an interesting question. They actually did 12 different analyses for various subgroups using a modified intention to treat analysis and various per protocol analysis. And when you look at it, 9 out of the 12 analyses showed non-inferiority. So 9 out of 12 when they did this. While 3, again, didn't show non-inferiority. So if they changed their non-inferiority margin to 5%, I looked at the data again, and it looks like only 5 out of the 12 could they claim non-inferiority. So I'm not exactly sure, but they certainly looked at a lot of data, a lot of different ways, and then presented what they felt was most important.
Now, the drug company or the authors of this particular study, the authors, in quotation marks, of this particular study, they want to play up the benefit of their drug. That's their job. It's the job of the medical industry, specifically in this case the New England Journal of Medicine, to be a little bit of a gatekeeper. So we have an answer for why the drug company, why the authors would have used this particular analysis. Why would the New England Journal of Medicine publish such an analysis knowing all these weaknesses? I mean, this is supposed to be a journal that understands statistical manipulation, how doctors can be fooled, for lack of a better term, with these things, and the fact that we trust these resources. So why would they publish something like this? And we don't have answers to that question. We have lots of hypotheses, but one of the things that we have to remember is how journals make their money. Journals don't make money by selling issues of the journal. They don't. How many people here subscribe to the New England Journal of Medicine?
Well, you know what, I don't.
Yeah, there's like 2 people who raised their hand. That's not how they make their money. They make their money by reprints, by the drug company ordering reprint after reprint after reprint of the article that shows a positive benefit for their drug. And then those get distributed in doctors' offices. So that's how they make money, and that's why they would publish something like this. And that's why we have to be very skeptical of all of these journals and think, what's their reason to publish a subpar study? And we're now seeing this over and over again with the New England Journal of Medicine and with many other journals publishing subpar research because it will help them sell reprints.
And I'm going to temper some of his statements. I mean, you know that I'm the skeptic, but I'm also going to be the kind individual who says, but they're in the business of making money. They've got every right to make money, right? They have a right to publish and make money from the research that they're doing. But what we should be is skeptical. And I remember when I first started out, I was like, well, if it was published in the New England Journal, there's smarter people than I, reviewing that, I can just read the abstract. Oh no, you can't just read the abstract. And it was a sad day when I realized it. Well, it was sort of mixed emotion. Sad, but also it was like, whoa, wait a minute. I can't trust everything that's been published, and I can't even trust things that have been published in the New England Journal. I must learn critical appraisal skills, and I must be skeptical, because I can be easily fooled.
So our last point, and we talked a little bit about this, is why was linezolid the comparator drug? Why was that chosen as a comparison? Because I don't think any of us would reach for linezolid as our first-line choice for cellulitis or skin and soft tissue infections. Most of us would reach for cephalexin. If you thought MRSA was at play, maybe you'd reach for Bactrim, depending on where you work, maybe clindamycin, maybe doxycycline. But I don't know, I've written for linezolid a small handful of times on patients who are being admitted, or on someone who has an ID doc who's like, hey, can you please prescribe this person linezolid because I already know their resistance pattern. I can count the number of times I prescribed linezolid on one hand.
I can't remember the last time I prescribed it.
So why linezolid? And again, a lot of this is because when the study was started, the price point of linezolid was pretty much the same as the price point they wanted to set for omadacycline. So they wanted to have a comparator where the prices were pretty much the same. But again, now linezolid has dropped off patent. It is considerably less expensive, and so they don't quite have that benefit anymore. $415 per day versus $5 per day.
So those are the 5 points we wanted to talk about in the nerdy section, and now we comment on the author's conclusions and compare them to the SJAM's conclusions.
So the author's conclusions were that omadacycline is non-inferior to linezolid for the treatment of skin and soft tissue infections in terms of early clinical response at 48 to 72 hours. However, the study's design has numerous flaws, and omadacycline is not cheaper, easier to use, or have less side effects than standard treatment.
And so we have the bottom line, Swami.
We do not recommend the routine use of omadacycline in the treatment of skin and soft tissue infections.
And we always like to resolve the case that we presented.
So you decide to go with your first thoughts, your original thoughts for your particular patient. You prescribe her a course of cephalexin, 500 milligrams, 4 times a day for 7 days, and you schedule a return visit in 3 days to see how the patient's doing.
And how do you take this information, this new publication, and apply it clinically? Because remember, evidence-based medicine is about the literature, which we've just reviewed, but then you have to apply your clinical judgment. So how are you going to take this study and apply it clinically?
Our usual first-line treatment of skin and soft tissue infections should continue to be cephalexin plus or minus trimethoprim sulfamethoxazole, or TMP SMX, for patients at risk for MRSA.
And then the final thing is, how are you going to have that conversation with the patient? Because we've just done a very nerdy review, a journal club-like review, but we've got to be able to translate that and speak at a patient level, right? We can't speak medicine. In most cases, we have to speak English, and we have to speak it so that they can understand. So how do you convey this information at the patient bedside? What do you tell the patient, Swami?
There are lots of antibiotics that are effective in the treatment of cellulitis. Cephalexin is a tried and true antibiotic, and most patients will improve with this drug. You can expect that there may be some mild expansion of the redness over the next 24 to 48 hours, but after that time, you should see a recession. You should see that cellulitis start to recede. Come back here or see your doctor in 3 to 4 days to check out and make sure it's progressing well. If you develop a fever, have vomiting, you can't take your pills, or you're worried about anything at any time, come back and we'll be happy to see you.
And so one final part of this is the Keener contest. And the Keener contest, I've explained this before, but a Keener in Canada is that medical student who sits at the front of the class and answers all the questions, put their hands up. Now, I understand in the U.S. that's referred to as a gunner.
A gunner.
We're just like Americans, except we cover our arms, because you have bear, right?
We have bear arms.
You have the right
Yeah, we have
bear arms.
bear arms.
Now, arming bears, that would be scary. And so we call them Keeners, not gunners. But we have a competition with a trivia question at the end. And the first person who gets the question right gets a cool skeptical prize. And so last week's winner, well, there wasn't one. No one got the question. I know, and that's always wah, wah. And the answer was the American College of Emergency Physicians, ACEP, launched the Geriatric Emergency Department Accreditation Program in May of 2018. We have a Keener contest or a gunner contest. I'm told by my wife I'm not allowed to talk about guns, abortion, politics, or religion when I'm south of the border. So we've tried to come up with something very benign. And if anybody after this gets the Keener contest, don't shout it out, but come up to me and I will give you a prize for getting the question right. Okay? Swami, you get to give the question.
So here's our question. Omadacycline is part of what class of antibiotic drugs?
If you know the answer to this Keener contest question, then send an email to the sjam@gmail.com with Keener in the subject line. The first correct answer will receive a cool skeptical prize. Now, there are some other FOAMed resources on this paper, and it's been covered by our good friend Salim Razai over at Rebel EM, and our other good friend Rory Spiegel has talked about this on EM Nerd. So thank you, Swami, for coming on the SJAM.
Thank you for having me.
And I want to thank the New York ACEP group. At the end of every podcast, I have my tagline, and I want to recruit the audience in to read the tagline in your best New York accent. All right? So on the count of 3, can you read the following sentence? 1, 2, 3.
Talk to everyone next week. That's it.